Welcome, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today we have a distinguished panel joining us to discuss an important advance in pain management in the emergency department using a specialized form of aspirin and oral ketamine. Here to discuss this new study is Dr. Sergey Motov, Professor of Emergency Medicine and Director of Research in the Department of Emergency Medicine at Maimonides Medical Center in Brooklyn, New York. Also joining us is Dr. Joseph Habboushe, Assistant Professor of Emergency Medicine at Weill Cornell Medical Center in New York City, and co-founder at Vitalis Pharma. Welcome, gentlemen. I really appreciate you taking the time to join us.
Thanks so
Thanks for
much.
having us.
Of course. Joseph, I want to start with you. And it's very interesting how this aspirin that you describe in your study, VTS aspirin, has a very integral role in terms of its actions with ketamine. And I wanted to start off and let you describe what exactly VTS aspirin is and its mechanism and the rationale behind its use.
Right. No, thanks so much for having us, first of all. We were trying to solve a very well-known problem in medicine, which is we don't have that many great pain medications out there. And ketamine, which has been approved for decades, we know that in low subdissociative doses, actually some other studies that Sergey had done in the past showed, is a very powerful pain medication. But the problem is ketamine is limited in a few ways. So number one is that it doesn't work that well orally. It doesn't have good bioavailability. Number two is whenever you do see good pain reduction, you typically see dissociation and sedation rates that would limit sort of outpatient or more common use. And the third is how long it lasts. So a single dose of ketamine, wears off after about an hour. So that's not great for oral use as well. So we wanted to find a way, can we address these three known issues in ketamine? Because if so, maybe we're going to be able to unlock a really powerful new drug that doctors can use to help their patients. So how we got there, we actually were trying to repurpose this VTS aspirin, this aspirin formulation we had come up with years ago. And this aspirin formulation, which we're calling VTS aspirin, was originally developed to solve a totally different problem. So if you remember, high dose niacin for cholesterol, vitamin B3 in really high doses, we knew do tremendous things for your cholesterol, and it used to be a very commonly used drug, but it had a patient-centered side effect that really bothered folks. It caused this painful, bright red burning of the skin. And my father actually was on this drug, and he wouldn't take it as much as he should because of this side effect. And it bothered me so much because we already knew that taking an aspirin 30 or 60 minutes before would actually significantly reduce that flush. But getting that timing right was really hard. And of course, people who are on cholesterol medications are on aspirin anyway. It seemed like a problem we should try to solve. So over a few iterations, we eventually came up with a formulation of aspirin you could take at the same time as the high dose niacin, and it would lower the flush. Eventually, we found out that this was also helpful when combining with ketamine.
So, Sergey, I want to bring you into this. In terms of the action of aspirin, this specialized form, with ketamine, how do these two interact? And is there a potentiation mechanism? Because from what I've read, there may be some effect on the receptors, the NMDA receptors, and that could actually reduce the analgesic efficacy of ketamine. So it's kind of a paradoxical approach from what I'm trying to understand here. Maybe you can clarify this for me.
Aspirin sort of modulates the NMDA receptor presence towards increasing it. And at least in theory, one suspect that maybe at some point it can diminish the analgesic efficacy of ketamine. But results of the study, I'm jumping ahead of myself, we're going to talk about it later on, show completely different entity. So to our great amusement, actually, they seem to work synergistically very well. And, it could have postulated maybe there's some anti-inflammatory properties or some anti-nociception plays a different role in the synergy. But I'm a firm believer that maybe for some unknown reason, as of yet to discover, there's some great deal of synergy combining a COX-1, COX-2 enzyme inhibitor and an NMDA receptor antagonist.
I see. And so obviously, I wanted you to jump into the results of the trial, the study design, primary and secondary outcomes, need for rescue analgesia, and go through the study with me and really, to let our audience understand what you found on this pilot trial.
So I'd love to. The first, again, the idea was to put a pilot together. It was a prospective, single-arm, prospective interventional study, sort of proof of concept, because as of right now, I don't believe there are any EDs who ever done oral ketamine on this scale that we've decided to do, especially in combination with proprietary VTS aspirin. So 25 adult patients, and I'll tell why we've chosen this number, presenting to the ED with a variety of acute musculoskeletal pathology. The reason we've chosen musculoskeletal pathology, that's the frequently used. We use NSAIDs and we use ketamine in my shop, and that's one of the most common reasons patient can come in and require oral analgesia in comparison to parenteral. So idea or hypothesis or rationale was behind the fact, let's look at the feasibility with respect to overall analgesic efficacy and tolerability, and of course, presence or absence of adverse effect. As Joe mentioned earlier, that ketamine is notoriously known to cause a significant degree of dissociation and sedation. So single-arm prospective interventional study. Patient received a 2-capsule, 324 milligram of VTS aspirin with a specific instruction to suck on the outer layer of the capsule for about 30 to 45 seconds and subsequently swallowed. And we use an injectable version of to use it orally. And patients were instructed to sort of swish liquid ketamine in their mouth for about 45 seconds or so and subsequently swallow, which exactly sort of, imitates the proprietary novel mechanism release of VTS aspirin and ketamine. So we use the research pharmacist to help us with the preparation of the medication. We add a little bit of sweetener to offset the bitter taste of ketamine, and we used dose of 0.5 mg per kilo. Reason we've chosen this voice, there was a pretty much minimally effective dose in a study by Littner, who used oral ketamine for patients suffering from burns when they underwent burn wound dressing changes. That was shown to be minimum effective dose. And as you know, my prior studies, I'm very big on using lowest effective dose as potential to offset a great deal of adverse effect. So we've enrolled 25 patients. Why? Because we use effect size of 1.3 as a minimum clinically significant difference in the pain change score from the baseline to 60 minutes. We use standard deviation of 3. We use one-sided t-cells with 97% confidence interval, and that's how we come up with the number. So here are the results. 20 out of 25 patients up to 60 minutes post-medication administration achieved greater than 1.3 change in pain score. 60%, which is 15 out of 25, achieved greater than 4-point change from the baseline to 60 minutes. Clinically, it translates to 44.7% reduction in pain score from the baseline. This is one of the largest we've had from the oral perspective. I can tell you, I've done studies on oral NSAIDs, and we're talking about 1.7, 2.2 points, somewhere between 30%. This is whooping 45%. But more importantly, only one patient had a moderate degree of dizziness at 30 minutes, and one patient had moderate degree of sedation. The best part is only 4% of patients, which is actually one, experience moderate degree of feeling unreality, which can be equal to a dissociation at 30 minutes, which basically resolved on its own at 60 minutes. So we've concluded that majority of patients, 80% of patients, experience greater than greater than minimum appropriate effect in pain score change from the baseline to 60 minutes. And as I said, 60% of patients had a greater than 4-point relief from the baseline to 60 minutes. So results were very, very encouraging.
Since it's only 16% bioavailability orally, doesn't that from the get-go mean that you're giving someone really such a fractional dose of ketamine in the oral delivery route? And how does that really play out? In other words, if it's such a small dose, how would that compare against just an NSAID, or just or simply another arm of the trial as a comparator?
Yeah, that's a great question. And when you take drugs orally, of course, they act different than if you get it IV or transmucosal or what have you, because of first pass metabolism. It actually happens for both of these drugs, right? So ketamine rapidly transforms into norketamine. Now, remember, norketamine is actually an active metabolite of ketamine. It just works a little bit differently. So the way we're giving it to patients is meant to have as much transmucosal absorption as possible. You can see Sergey was describing that even the ketamine was swished around the mouth. The aspirin is also designed to do that. So there might be some avoidance of first pass metabolism, which will help with this. What I think we are also most likely seeing is some kind of synergistic effect of how aspirin, which is known to upregulate part of the NMDA receptor, which again, you would think would hurt the, the beneficial effects. There's probably something going on with that in terms of the ketamine and norketamine and the NMDA receptor and how there is modulation of the NMDA receptor with aspirin.
And sir, is there research at a deeper level, on a molecular level, to try to figure this out receptor-wise? Is there anything that your company or Sergey, in terms of any further inquiry into that, into the exact mechanism regarding the two synergistically?
Well, not at that level did you describe, because I'm primarily geared towards clinical research studies on humans, and the only right, the potential study is to actually randomize subject to different concentration, different dosing regimens, and check the blood levels and see and compare it to existing. You mentioned, if oral bioavailability about 16 to 17%, what it would be interesting to see what would be the Cmax or Tmax of the oral ketamine that is partially absorbed in the oral cavity and subsequently swallowed. And you can, if you find healthy volunteers to that extent, not necessarily the patient, and measure the concentration at 15, 30, 60, 90 minutes and compare. And look, it's all theoretical. Look, I'm happy we're having this conversation. All of a sudden, you're giving us great ideas. But as of right now, that's where we stand. It's purely clinical, and it's purely on patient with acute pain in the ED.
Right. So in terms of throughput, looking at length of stay, in your experience, obviously from this pilot, do you see this as a reasonable approach that would, adhere to guidelines in terms of quickly getting people managed, treated, and then discharged, in your view?
Yes. So as I mentioned earlier, both of us, we were very encouraged with the results. And look, we all have taken NSAIDs at some point in our lives. And we know it takes somewhere between 45 minutes to maybe an hour or two to kick in and feel some sort of relief. So even somebody comes with a grade 2 sprain or big contusion that I consider giving NSAIDs plus ketamine, I need somewhere between 45 to 60 minutes to at least observe the ND for some mild to moderate efficacy of effect, and they'll be comfortable to go home with. What amazed us, what really, really encouraged us, is that adverse effect related to ketamine administration, specifically dizziness, was very short-lived and disappeared in most of the patient by 30 minutes. And those moderate intensity adverse effects were gone by 60. And none of the patients experienced severe side effects, such as abnormality in vital signs, altered mental status. They didn't go into a K-hole. They did not require rescue benzodiazepines. These are things what sets up the precedent that maybe with the future studies, maybe a combination of oral ketamine with a novel mechanism of release and VTS aspirin will be a great analgesic alternative, or the drug managing variety of acute painful condition in the ED and outside of ED, as you pointed out, let's say fast track, for instance.
Right, because I think that, on everyone's mind is, as long as this doesn't delay throughput, and certainly if patients, are responding, that's, obviously a big positive. What about treating migraine headaches, things of that nature, other types of pain, renal colic? Is there any thought about that at this point?
Yeah, I think, and just going on what Sergey is saying, this is all hypothesis generating, right? This is a pilot study, really early days for sure. And so we want to see this repeated in randomized controlled trials. But it is pretty exciting. Another thing I'll add is in Sergey's study, they measured pain till 120 minutes, so 2 hours, and he still had good pain reduction at 2 hours. There's a few oral ketamines that have been out in some other countries that are used in small procedures in clinics where you see a little bit of pain reduction that wears off after an hour. So that's also very promising, but we need to repeat these studies. We need to make them randomized. I would love to see them. We're talking to some folks in post-operative pain, especially some post-operative patients need to be on aspirin anyway for VTE prophylaxis. So it might line up really well with what they would potentially be doing.
I mean, maybe VTS aspirin alone itself might have an effect without ketamine that would be interesting to study that in that separate arm, obviously in a larger study and play that out.
Oh, yeah, totally. And as you know, right, aspirin is the most commonly used over-the-counter medication for headaches. And you're right, just you have this type of formula with a rapid release, partial rapid release will be beneficial, might be beneficial. But again, hypothesis is a beautiful thing, but we need to have studies to prove it. So my big points would be 3 points, and then obviously I defer to Joe, is that synergy for some unknown ways as of yet to do between aspirin and ketamine is palpable. And even the small pilot study was very encouraging. Second, the ability of oral ketamine sort of be given in a way that part of it gets absorbed in oral cavity might have a great deal of faster onset of analgesia, which could be very, very beneficial in variety of acute painful presentation in the ED. And the last part, which is probably more important to me, is that incidence of adverse effect by combining oral ketamine and VTS aspirin were significantly lower in comparison, indirect comparison, but very indirect comparison to all the studies in IV and even nebulized ketamine that my team and myself conducted at my shop for the past decades. So these are 3 points.
Okay. And Joe?
Yeah, no, thanks. What I get really excited about is trying to figure out how to use existing medications to solve problems. There's so many new medications are coming through, which is great, and we need to sort of push the boundaries with new medications. But as a practicing doc, I want what is safest for my patient. So I love this idea that we've potentially been able to find a way to take a drug that already exists that has some really great pain benefits, and then maybe address these sort of known limitations. Again, making it work orally, having the side effects low, but still good pain reduction, and having it last a little longer. And it seems like those 3 things are getting addressed here. So to me, this is potentially very promising, but a ton of work to do to really repeat this and prove that it's actually there, because this is early days, as we talked about.
Absolutely. And certainly this is opioid sparing, and that's obviously a big positive here. And I mean, no one can argue that that's a big effect. Is there any addiction potential here that you see? Patients that feel a certain way and then come back or even request the medicine that you see in the future as being an issue?
So I may start. So Robert, as I mentioned earlier, I have a decade worth of studying ketamine in a different route for different patient, different group of patients, pediatric, geriatric, adults, given intravenously, subcutaneously, short infusion, subcutaneous. And I got to tell you, I've had scores of patients through my research and my daily practices, and I've yet to see a patient who would come back to my emergency room and say, I would like to get ketamine because I felt very good about this. And again, we haven't measured a high. Don't get me wrong, ketamine is associated with a high. That's why it's recreationally used, but on the dosage regimen that is almost 3 to 5 times higher, the one that we use for medicinal or research activity to that extent. So the fear is always there. Is it substantiated? Of course, but I believe maybe there's another hypothesis generated thing that maybe having VTS aspirin entity will offset that potential high associated with ketamine, and ultimately the incidence of it would be so negligible that it's actually going to be very legit and a good medication, combination of such to treat patients.
Yeah, and thanks, Sergey. And just adding to that, ketamine is a scheduled drug by the DEA, right? So we take that very seriously. It's a lower schedule than opiates for obvious reasons. Very hard to overdose on ketamine. But also our best understanding, or medicine's best understanding, is that the addictive potential is related to the out-of-body feeling, the dissociation of ketamine. So the hope is, if we're showing lower dissociation rates, and we're also using actually a much lower dose than you typically see in recreation use, then maybe we have a safe drug. But again, early days.
Do you see also there in terms of outpatient prescribing that this one day might have some role in the outpatient realm, so to speak, as opposed to just ED or urgent care setting or primary care setting?
I would say, if we can see that this works and it has low side effects and it's safe and the FDA agrees with that and all that, then there are some use cases that could be really beneficial. And that's why I mentioned earlier postoperative pain, because we know that when we send patients home postoperatively, a few of them will take some opiates, and months later, some of them are still taking opiates. And this is a problem that I think we can address if we have powerful, potentially less addicting medications. Again, early days here, but I could imagine in those periods of a high acute postoperative pain. And that's where I'd love to see this studied next. And we're talking to some folks who are researchers in that space now.
Yeah, and if I can add to it, it's same from ED perspective, since we all 3 of us are ED docs, the acute pain and the first 24, 30, 48, up to 72 hours post ED discharge, this is, I personally see, the great use of this combination shall prove to be so efficacious in obviously larger scale randomized double-blind, 2 or 3 arms studies, because that's what we do as a primarily ZZ docs. We take care of patient in acute pain, and if it can alleviate pain and suffering with the less degree of adverse effect and beneficial profile, analgesia, and harms in comparison to even opioids, that's everybody wins.
Thank you again both for taking time to discuss your research, and it's again very important, I think, and groundbreaking. Thank you again.